one guy, okay? And again, this is real life. A patient, I'll tell you, they happen like this all the time. Nothing is ever straightforward, okay? So really quick, A&P review. Okay, this is a great picture. We talked about all of this stuff, right? 4 chambers of the heart, right atrium, right atrium, left atrium, right ventricle, left ventricle, okay? We talked about the layers. We talked about endocarditis, right? The innermost layer, okay? Myocardium is the middle, and then epicardium is the outer side, right? And then around this is the pericardium, okay? Where we talked about the pericardial sac that the heart sits in, okay? Got about chambers, and then lo and behold, look at that. All the valves, okay? Quick, down and dirty. If you need to understand the flow of blood, this is great arrows, okay? This might be a great diagram to have next to you when you're looking at the valvular disorders, okay? Okay, conduction, right? So if you watch Professor Tausnick's and my lecture, he went over this, okay? The SA node is the primary pacemaker, right? What is the intrinsic rate of the SA node? 60 to 100, I love it. The AV node is the delay and relay the impulse, okay? That is, the AV node is what gives us our atrial kick, okay? We need the atrial kick. Why? Because that's 30% of our cardiac output, okay? So when they go into some sort of weird atrial arrhythmia, we lose 30% of our cardiac output. It's a big deal, right? When you hear lub-dub, that's what the AV node is helping with, okay? That relay and delay response, okay? If you didn't have that, you would just hear this, okay? But with lub-dub, you hear that, right? S1, S2, okay? Now, that's important, okay? AV node, we love that, okay? It's the lub-dub. AV junction, that includes the bundle of His, right? What's our intrinsic rate of that? Anybody remember?
40 to 60.
40 to 60, excellent. It's the backup. It's the backup to the SA node, okay? Bundle branches, there's one right, one left, and then we have the Purkinje fibers, right? What's our intrinsic rate for that one? 20 to 40, excellent, good job. And that's the backup rate to the AV junction, okay? I'm not gonna ask you a question on the test that says, what is the Purkinje rate? I'm not. But I need you to understand that that is what's going to guide some of our rhythms, okay? So if you have issues in the heart where you have ischemia, that's going to cause arrhythmias, okay? Does that make sense? So it's important to understand the conduction pathway and what you could be seeing in terms of arrhythmias that could develop, okay? Because again, you guys, those are knowledge questions. I'm not going to ask you knowledge questions on the test. I'm just not. I'm asking you application questions. You're in block 4. We've upped the ante, okay? Here's our ECG characteristics, okay? How you are looking at a rhythm to determine what it is. These are the things you need to ask yourself. Do they have a P wave? Is it upright? What does the QRS look like? Is it narrow or wide, okay? Where is the T wave? What does the QT look like, okay? I'm not going to ask you what the P wave is, atrial depolarization. I'm not, okay? But you need to understand what this is. That way you can determine what the rhythms are. You will have rhythm strips on your test. They will be fill in the blank, okay? No spelling. Spelling, again, I've had lots of creative spelling over the years. If I can figure out what it is, I will give you credit, okay? So if you spell it wrong, don't stress about that. But you are going to have to identify it, okay? They're straightforward rhythm strips. Don't stress out about it, okay?
Can we just abbreviate?
Huh?
Can we just abbreviate?
Sure, as long as I know what it is. Okay, and then this is how the impulse spreads throughout, okay? So again, if something's wrong, it's going to affect the conduction, right? It's going to affect the electrical conduction. Okay, so who is Mr. Albert? 57-year-old male who is a retired teacher. He has a history of hypertension, dyslipidemia, and obesity, okay? He's been trying to quit smoking cigars and lose some weight, but to no avail. He's failing. He's tried, he's failing. He has recently been diagnosed with coronary artery disease and stable, I've capitalized that, angina. His father and mother both died from MIs. Sad for him. Okay, what are some modifiable risk factors for coronary artery disease? And then what are the non-modifiable? Take a minute and type them out.
Diet, smoking, drinking, exercise.
So remember, modifiable, things that you can change. Things that you're able to change. And then non-modifiable, things that you cannot change. Okay, so modifiable are things that you can change, right? He can stop smoking his cigars. Okay, has he done that? Nope. He can lose weight. That's modifiable, right? Lifestyle change. He can exercise. He can lift weights. He can go walking afterwards. Obesity. That is something that you can change, right? He could take medications for that dyslipidemia, hyperlipidemia, okay? For that hypertension, he can take meds for that. The non-modifiable are genetics, okay? He can't change the fact that his mom and dad both died from MIs, okay? He cannot change the genetics that he's probably predisposed to having an MI, okay? So things that you cannot change are genetics, okay? But things within your grasp, right, are stopping smoking, eat healthier, lose weight. He can't change how old he is, right? He can't change his gender, okay? So lots of things that he cannot change. What? Well, I guess that I misspoke. But he can't change his genetics with his parents, right? That they both died of MIs. Okay, so let's talk about Mr. Albert's heart rhythm, okay? So let's talk about the first strip, okay? Now, what is the rate? What is the rate of the first strip?
7.
Okay, so you think it's 70, right? We're not going to really count this one because I can't really see it, okay? So 1, 2, 3, 4, 5, 6, 7. Professor Blur, how'd you get that? Well, this is a 6-second strip. You count the QRSs, you multiply them by 10, and that's how you get the rate. So 70, right? Does everybody understand how I came to that conclusion?
Yes.
Okay, excellent. You will always have 6-second strips on your exams, okay? So you never need to determine if it's anything but. This is how you need to determine the rate, okay? Now, what would I call that rhythm, that first strip? The rate 70, what would I call it? Normal sinus rhythm, okay? Excellent, so sinus rhythm. Why, how can I determine that? Well, there's a P for every QRS, it's upright. QRS is narrow, right? So it's sinus. Now, I'm not doing any sort of trickery. I know you guys all think I'm into that, but I'm not. I'm actually very straightforward. But why did I put the second strip? What is the second strip below it?
Someone else's.
Okay,
Because they're
sure.
different.
Sure. So what's the rate of that one?
80.
80. Okay. 1, 2, 3, 4, 5, 6, 7, 8. I'm counting, again, the QRSs, right? So why I included this? First of all, what's the rhythm? Normal sinus, right? Normal sinus rhythm, okay? And it's at a rate of 80, okay? Why I included this, it is so important to understand. You can look at the monitor and everyone's rhythm looks different, okay? So again, both of these rhythms are sinus rhythm. There's a P before every QRS. QRS is narrow. QT interval looks great. There's a T wave, okay? T wave is a little bit higher than this T wave, right? So again, they're going to look different. Different rates, okay, because of the different QRSs, right? Different number of QRSs, but again, why I need you to look at this is just to understand that they're both sinus rhythm, okay, normal sinus rhythm, but they look different, okay? And this happens all the time, where you'll look up at the rhythm, you'll look up at the monitor in the ICU, if you ever had the chance to go, and all of the rhythms are displayed, and they all look different. Nobody looks the same, okay? But you need to be asking yourself these questions when you're determining what type of rhythm is in order to distinguish it, okay? Does that make sense? Okay. So we'll just talk about this. You don't need to write. Are you concerned about that heart? Let's talk about the first one. That heart rate of 70. Thank you. I was like, what was it? 70. Normal sinus rhythm. Are you concerned by that?
No.
No. Why? Okay. So it's normal sinus. But if I didn't have that monitor, let's say I didn't know, and I was looking at him.
He doesn't have any signs of symptoms.
Okay, he doesn't have any signs and symptoms of what?
Like,
Okay, distress, right? So what would he be if he's not in distress? Neurologically, would he be intact? So it would be ANO times 4. Level of consciousness, awake, alert, right? Would he be complaining of chest pain? Shortness of breath? Dizziness? Lightheadedness? Would he be pale? No, right? All of those things that I just listed would be signs of distress. Okay, Mr. Albert doesn't have any of those, so he's not in distress. He's not diaphoretic, he's not pale, he's not cool. His cat refill is less than 3. Okay, so he's showing no signs of distress. So again, he's stable. He's stable. Okay. Now, real quick review for you guys. Treatment for stable angina. What do we do? Nitro. Okay, what else? If you didn't do nitro, what could you tell the patient initially? Rest. Okay, so you're walking up the stairs and there's 10 flights and you're like, yeah, I can do it. Well, no, you can't. You need to sit down. Sit down, have a rest. Okay? So stable angina, right? There's chest pain. How you treat it, you stop what you're doing, you rest. You may give yourself some nitroglycerin sublingual, and that should do the trick, right? Either the rest or the nitro should take care of the angina. That would be the stable part of it. Does that make sense? Is this reviewed for you guys? Hopefully, okay? Okay. Uh-oh. Mr. Albert is trimming his trees in his front yard. He becomes diaphoretic and reports chest pain. Okay, this is his heart rhythm. Okay, so again, no trickery here, but I'm doing this to show you how things look a little bit different. So the first heart rhythm that we have, first rhythm strip, what do we have? Okay, so the rate is, you're saying 150? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 150. So what would we identify that as? Okay, is it sinus? Okay, sinus tachycardia. Excellent. We have a P before every QRS that we can see. QRS is narrow, right? So we have sinus tachycardia at 150. Okay? And then the rhythm strip below. Again, I just am doing this to identify and demonstrate that they can look different. What is my rate on this one? Oh dear. Oh, it's touchscreen, that's fun. Learns all the new things. Okay, so what's my rate here?
120.
Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 110. Okay, 110. QRS is a little bit wider, right? It's probably not abnormal, okay, but a little bit wider than the one up here, okay? Both sinus tachycardia. What are you going to do about this? What do you need to do?
Find a reason.
Find a reason. I love it. So we don't arbitrarily just treat sinus tachycardia. What drug could I give him to treat this? To slow down the heart. You could give adenosine, but it's not that fast.
Single.
What?
Just normal single.
Okay, because you think what?
Also
love it.
dehydrated.
Okay, I love it. Yeah. So dehydration, but again, we're not just arbitrarily throwing a beta blocker, right? Because that's certainly going to slow him down. We want to know the cause. Alex has said that he's dehydrated. Does it make sense? He's outside, it's Phoenix, it's hot, he's sweating, right? So we give him some saline. That will hopefully help him slow down. I love it. What else could you do? Remember, he has stable angina. He's trimming trees. He's doing something active, and he's reporting that he has chest pain. So what could you tell him? Stop. Sit down, right? Stop what you're doing. Sit down. Exactly. Sit down, take a drink of water. I love it. So we think, remember, high is dry. Sinus tachycardia, one of the first things that's going to happen is that when you're dehydrated, is that you can have sinus tachycardia, okay? So again, we want to know why, okay? What if I were to take his temperature and his temperature's 40? Because it's 130 degrees outside and he's trimming trees. Could that drive up his heart rate? Hyperthermia? Okay, so what would we do about that? Sit down, drink water, cool cloth. Maybe he needs to go inside in the air conditioning, right? Pack himself in ice, right? Under the armpits, in the groin, okay? So he's hot, okay? What about he just cut himself with his shears? Pain. Pain is the cause of sinus tachycardia. Again, what is the cause? Treat the cause for sinus tachycardia. Okay, let me repeat that. Treat the cause for sinus tachycardia. Figure out what the cause is, okay? Perfect. And then he reports chest pain, so he stops what he's doing, and what drug could he take? Remember, he has a history of stable angina. Nitroglycerin, perfect. So how is he going to take? I like it. So if his blood pressure is not, I mean, again, in this point, is he taking his blood pressure? Maybe. Hopefully it doesn't feel dizzy and just pop one in arbitrarily, right? But great point is that we want a good blood pressure before you give nitroglycerin, okay? So hopefully we're teaching people to have a blood pressure machine at their house, take it before you pop one in, right? That's best case scenario. Questions before I move on? Okay, so, oh dear, things are progressing badly. No, Mr. Albert has stopped trimming the trees. He's taken 3 doses of nitroglycerin sublingually, and the chest pain has lasted more than 20 minutes. He also complains of severe back pain, okay? He displays this rhythm. Okay, so first and foremost, what's my rate?
That's what I was going to ask her. Is yours going to look like that, or are they going to look like that?
Maybe they're gonna look like that.
Do we readjust?
I'm scared for
What do you mean, do they readjust?
Readjust the needs.
Yeah, but I mean, he's moving around. This is how your patient's gonna live, my friends. Maybe, but yeah, I mean, you can tell him it's not moving, so he doesn't have that artifact. But this is how it could be, you guys. This is how it could be. So take a deep breath. Don't stress. Break it down, right? Okay, so how many QRSs do you count? How many?
5 that I've noticed.
5. So remember, again, QRS. Is this a QRS? No. What are they?
PACs.
Close. PVCs, okay? Wide and weird are PVCs. Where is this being generated? In the ventricle. Wide and weird and big, ventricle, okay? So these, oh my gosh, sorry. Premature ventricular complexes, okay? Premature ventricular complexes. You have 3 here, 2 here. But underlying, right, we look for that PQRS situation, okay? So you have 1, 2, 3, 4, 5. So the rate is 50. So what you would say about this is that it's what? Sinus Brady, right? A rate of 50, sinus Brady with some PVCs, okay? Now, are PVCs bad?
No.
Not necessarily, right? You guys are probably all having PVCs right now, okay? I'm probably having some PVCs if those people are to come in, right? Okay, what causes PVCs? Oh man, this is where you look up at that PowerPoint that I've given you. This is where you open your book. What causes PVCs? Stress, hypoxia. That's actually the #1 cause. Well done. Hypoxia, stress, anxiety, pain, caffeine, drugs, electrolyte abnormalities. The list goes on and on and on. okay? When you are concerned about PVCs, we probably have them. Have you ever felt like a palpitation? You probably just heard PVC, okay? When you're concerned is when you have them more frequently. You need to pay attention, okay? When your patient is having them more frequently. So he had 3, then a normal, essentially B, right? And then 2 more. So the frequency is a concern, okay? Does that make sense?
Yes.
Okay, and then look at what is going on in the scenario, okay? He still has chest pain despite taking sublingual nitroglycerin, despite resting, and it's lasting more than 20 minutes, excuse me. So what is this progressing into? Okay, possibly, but if you looked at the acute coronary syndrome, okay, what could we say about his angina? Is his angina stable anymore? No, it is unstable. Okay, does that make sense? It's unstable. Okay, questions about PVCs? No? Okay. Oh, no, but look at, this is what I'm gonna do. I'm so excited. Is this gonna work? Yes. Okay, the saga continues. Mr. Albert, because he's crazy, refuses to call EMS, and Eleanor, his wife, is like, I'll drive you, no problem. Not a good idea. Please ride in the ambulance, okay? So what's our action plan? What's our treatment? He lands in the ER. What are you going to do? What can you anticipate? Go ahead and write it down. Okay guys, let's talk about this. So, what is happening at the cellular level, right? The heart muscle is becoming hypoxic, right? This can happen in the first like 10 seconds, okay? Time is muscle, okay? We want to preserve the heart muscle, okay? After 20 minutes, we have cell death. We do not want that, okay? Especially if you have no collateral circulation. So we know that he's having cardiac ischemia, right? We need to figure out what's going on. So our action plan is that we should be putting an IV in him, right? We should be hooking him up diagnostically to a 12 lead. Do I see that up here? Yes, well, yeah, 12 lead. Okay, 12 lead is so important to look at what's going on in the heart. And then the labs you want to send is a troponin. Troponin is more specific than a CKMB. Okay, troponin is what you need to diagnose ACS. Okay, acute coronary syndrome. We're going to be talking about the 3 facets of it. The first thing is unstable angina, which we think Mr. Albert has, right? So you're sending a troponin. You're doing a 12 lead. Okay, you can send a CKMB. Okay, you can send those other labs, but troponin is going to be your more specific one. Okay. And then you are going to be utilizing MONA, okay, MONA. Not necessarily in that order, okay, but you are going to be putting the patient on oxygen, okay. We know that there's ischemia happening in the heart. What is ischemia? Lack of oxygen. Don't you think we'd like to put our patient on some oxygen to help them, right? To help them. So again, you're putting them on oxygen, okay. You are giving them an aspirin. Why am I giving them an aspirin? To what? So prevent that clumping, okay? So what is going on pathophysiologically, right? You know I love my patho. We don't have a lot of time to talk about it, but you have an unstable atherosclerotic plaque that has happened, okay? Somewhere in the heart, okay? What happens is that when that plaque becomes unstable, right, and there's some sort of occlusion happening, platelets start to clump there, right? Platelets start to clump, and we don't want that. We want the Teflon, we want the Pam, we want the olive oil on the platelets to just go on by and do not clump to make the problem worse. That is what an aspirin does. It prevents platelet aggregation, platelet clumping, okay? Does that make sense? So you give an aspirin to prevent that. That's why oftentimes at home, you tell people, take an aspirin right now, because that's gonna prevent the problem from getting worse, okay? And then nitroglycerin, okay? What would be a question I'd want to ask Mr. Albert before I give that nitro? Do you take any Viagra, any erectile dysfunction meds? Do you have pulmonary hypertension? Okay, sildenafil is a huge one. Cialis, Viagra, whatever. Remodulin is another one, okay? So do you have erectile dysfunction? Do you have pulmonary hypertension? Okay, because that would make you stop and pause, because you should not give nitroglycerin if they're taking those drugs, because you do not want to cause profound hypotension, okay? Let's see, morphine. Why am I giving someone morphine? Pain, okay, perfect. It's also a twofer, right?
It also decreases the preload.
Yes, perfect. So nitroglycerin decreases preload, right? So does morphine. It's a twofer. So it decreases preload, right? Decreases the work of the heart. We don't want the working hard. We want to decrease that oxygen demand in the myocardium, okay? Does that make sense? What about a beta blocker? Am I giving this guy a beta blocker?
No.
It's possible. Oftentimes you give a beta blocker in 24 hours, okay, if hemodynamically stable, okay, and there's no other contraindications. Okay, if this guy's in heart failure, you don't want to give him a beta blocker, because we don't want to block him down and decrease cardiac output already, okay? And then, how about an ACE inhibitor? Do we give this guy an ACE inhibitor? Oftentimes within 36 hours. Why we do that is to decrease ventricular remodeling, okay? But we're still trying to figure out what this guy has. Okay, so initial treatment is MONA, morphine, oxygen, nitroglycerin, and aspirin, okay? Questions about that? No? Okay. Okay, so Mr. Albert is admitted to the ICU. The 12 lead showed T-wave inversion. The troponin was negative, okay? Plan is for the PCI in the morning, okay? You are the night nurse, and you're about to go assess Mr. Albert. You walk in his room because his call light is on, and you see this rhythm on the monitor. Okay, so pause for just 1 second. 12 lead shows T-wave inversion, and troponin is negative. So we can say that Mr. Albert has what facet of acute coronary syndrome? If his troponin was negative and he has some T-wave inversion on his 12 leads, what do you think? What? What about the troponin? Is the troponin on NSME positive or positive or negative?
It would be
Positive, okay? So just like we said, we know that there's been some sort of EKG abnormality, T-wave inversion, but the troponin was negative, so he has unstable angina. That's what he has. But the problem is that we need to still treat that, so he's gonna buy himself a trip to the cath lab in the morning for a percutaneous coronary intervention to check out what's happening. Okay, he has stable angina, now it's progressed to unstable. Does that make sense? Okay. So you walk in and the call light's on because he wants some Jello. Mr. Albert's like, yo, I want some orange Jello. And you're like looking at him, you're like, huh. And then you're looking at the monitor, you're looking at him, you're looking at the monitor, and this is what is shown on the monitor. What's our rate here?
About 130.
Okay, so shall we count it out?
Yes.
Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 14, sorry, 15, 16, 17, 18, 19, 20, 21, 22, 23. So what is that? 230. It's kind of fast, right? Mr. Albert's like, yo, are you gonna bring me my orange Jello? I'm very hungry. And you're like, but your heart though, oh wow, okay. So what are we gonna do? He's tapping out. First of all, what is that rhythm called? SVT, supraventricular tachycardia. Okay, so he's SVT. Is he stable or unstable?
Stable.
Okay, how do I know he's stable?
Because he's talking to.
He's using a call light. He's asking for Jello. He's awake. He's alert. He knows what Jello is, right? He uses call light. What would be a vital sign that I would want to like maybe go over to the monitor and press the button to get?
Blood pressure.
A blood pressure. Okay. So one of the things that can tell me if someone is symptomatic or asymptomatic, okay, stable versus unstable, is the blood pressure. Okay. If he was unstable, how would he present? Confused. Okay, what else? We just talked about blood pressure. So
Lethargic, sweaty, hypertensive.
sweaty, hypotensive, pale, excellent. So unstable, right? He's stable right now. So in this moment, what should I encourage him to do?
Bear
Okay,
down.
bear down, right? So again, you can have him take this 10 cc plunger, okay, because you're trying to explain to Mr. Albert what bearing down is, and he's just like not really getting it. He's like, what? And you're like, have a bowel movement. He's still like not getting it.
Try to poop, but don't.
Right. But all you have to do is tell him to try to blow the plunger out the back end. Take the syringe, put it in your mouth, put it in your mouth, because that's gross, and blow it out. Okay, so he's going to bear down. Essentially, you're having him vagal. Okay, if he was intubated, how would you make him vagal? Suction. Excellent. Love it. Great. Suction. Make him cough, right? So that's the most non-invasive because he's stable right now, okay? So you try your best and, okay, we can move this. Vagal maneuvers fail. Now you're going to give adenosine, okay? Adenosine, right? We use this, a three-way stopcock at the bedside, okay? Why do we use a three-way stopcock like this? We talked about it last time. Has to go fast. It's a very short half-life. If I had a choice between a peripheral and a central line, what would I choose? Central, right? Closest to the heart, okay? So you invite a friend. Hey, you're my friend. Hi, can you help me? You're my charge today, okay? And so you're going to, I'm the drug, okay? And then you're the push. So you have to hold this because when I push this, it's gonna try to go back, okay? But I go first and then you go first, okay? So let's do it. Okay, you hold it. Ready? I'm gonna go. Ready? Do, go. See how quickly that is? You have a friend do this with you, okay? Usually it's your charge nurse. What would be something that I would like to attach to my patient prior to pushing adenosine? Pads. Okay? I'll pass these around. You could open them. I don't care. Is this an adult one? Yeah, adult child. Okay. Open that up. You want to put pads. This is not an operation that you're by yourself. The physician is at the bedside. Okay? The physician is at the bedside. You're hooking them up to a defibrillator. You're putting pads on them. How are you describing this to your patient? Mr. Albert, you want to educate him. What's it going to feel like? Yeah, please do. Please do. Play with it. Put them on. Whatever. Chest pain. You're going to feel not so great. You're going to feel hot and flushed. You're going to feel nauseous. You want to vomit. Okay? It's going to be short-lived. You're going to be okay. But for a short while, it's going to suck. Okay? It's going to suck. You're not going to feel great. What's the dose for adenosine? Everybody remember? Initial is 6 milligrams. That doesn't happen. What could you repeat it at? 12. Okay, could you 12 one more time? Okay. So you give adenosine. Okay. And you see this rhythm. What are we looking at? AFib. Okay, great. How do I know? How do I know it's AFib? So look at your R to R, right? That's one of the questions that you ask yourself is, does my R to R march out? Okay, so if you say march out, here's this. Here's the next one. Whoa. Here's the next one, right? So essentially when I say march out, are they evenly spaced? No, they're irregular, okay? Can you tell where a P wave is? Are there P waves in AFib? No. Okay, so how you can tell the two things with AFib is, do the R's march out? They do not, they're irregular. And is this a P wave? Is this a P wave? Is this a P? There's no P waves. Okay? So, if we were to determine the rate of this AFib, what would it be? So 1, 2, 3, 4, 5, 6, 7, 8, 9. 9. So 90. Perfect. Is he rate controlled?
Yes.
Excellent. He's rate controlled. Anything below 100 is rate controlled. Okay? So with AFib, are we worried about this? Can we leave him like this? What'd you say? Okay, so is he symptomatic with this AFib? Is he tolerating it? Is he okay in this rhythm?
Yes.
Yes, he is, because look at, he's displeased. He didn't love that you gave him adenosine, but he denies discomfort and he wants some jello. He just wants his orange freaking jello, okay?
Somebody just give him
That's all he wants, is he wants his jello. Come get his freaking jello, right? So again, AFib, is that a problem? In the interim, no. Why? Because he's not symptomatic, okay? If he were to stay in this rhythm long term, what would he need? What kind of drug would he need? An anticoagulant. Excellent, right? Because that atria is firing really fast. And then what happens is that blood pools and you can have clots forming. Okay, clots that can go to your brain. Do you want someone like him to have a stroke? To shower clots? No. So if he stays in this, you would need to be thinking about anticoagulation to prevent that intracardiac thrombi. Okay, intracardiac thrombi. But he's fine, right? He's fine with the AFib. Again, you guys, look at the rhythm strip, read the question, evaluate, is my patient symptomatic? Are they tolerating it? Even if it's an ugly one, like the one before with all those PVCs, okay? If he was awake, alert, oriented, he looked warm, he wasn't diaphoretic, his cap refill is less than 3, he's fine. Okay, does that make sense? Okay, so we're gonna skip this. We're just gonna go through this, okay, talk about it. So, oh, actually I do wanna talk about that. So if adenosine did not work and he became unstable, what would I do? He became unstable in that AFib. When I mean unstable, diaphoretic, okay, confused, level of consciousness decreased where he's lethargic, hard to arouse, hypotensive. What am I gonna do? Synchronized cardioversion, exactly, okay? Synchronized cardioversion. In your brain, make those two words go together. Synchronized cardioversion. Edison medicine. Okay, you're gonna light them up to convert him out of that rhythm. Okay? It's great, I love that people are doing this. Okay, so synchronized cardioversion.
Before that, we do try adenosine 3 times, right?
You can, absolutely,
Or
yes.
do it go,
Huh?
or like it doesn't work and it goes straight for.
So you can absolutely do adenosine. Oftentimes though, to be real, if 12 doesn't work first, they're not gonna probably do another 12.
So just 6, 12, and if it doesn't work, the cardioversion.
Yes, exactly,
If he's
sync cardioversion.
unstable, if he's unstable, he's gonna get sync cardioverted before they even do that.
Say it again?
If he's unstable, he would get a sync cardioverted before.
Correct, yes, absolutely. So unstable, synchronized cardioversion. Unstable, hypotensive, okay?
Stable gets meds.
Okay, Edison medicine. Hopefully your blood pressure is not so low that you can kind of medicate him a little bit, but sometimes you're just gonna light him up with nothing and it's gonna hurt like a mother. But hopefully you can give them maybe a little Versed, maybe a little fentanyl, okay? That would be the best case scenario. Okay, so it's 2 in the morning. You are heading to lunch. Excuse me. You ask Mary, she's been a nurse longer than you've been alive, okay, to watch your patients. She gives you a little side eye that says yes. Pertinent information to give about Mr. Albert. What's an S for? You guys. What are you going to say to Mary? You're going to lunch. You going to sit down and give her a half-hour report? No? Okay. So what are you going to do? What are you going to tell her about Mr. Albert? Because she's watching for you. You're leaving to go to the cafeteria. What do you think? What should you tell them? What's some pertinent information? What'd you say?
The amount of adenosine given.
Okay, okay,
She's
so,
invasive,
okay, perfect, love it.
stable,
Okay, what about code status? Do you want him to code, do you want her to code him if he codes? Okay,
Patient came in with unstable angina, went into SVT,
okay,
received adenosine, converted, now in AFibs,
okay,
but stable.
okay,
Full
perfect. Okay, and a full code. What would be another thing you'd wanna add to that? Maybe current set of vitals? What else? What else is important if you were to code?
He
What would you
really
wanna
wants
know?
that Jell-O.
What?
He really wants that
He really
Jell-O.
wants that Jell-O. He might put his call light on for Jell-O. But what else? If he were to code, what would be something that you are walking in to the room, totally not knowing anything about this patient, but what would you want to know? Okay, sure, yeah. Pulse is a great idea. How about peripheral access? If he's coding and you want to give code drugs, don't you want to know so you're not searching where is his lines? So something to say when you're telling your nurse, right? Hey, Mr. Albert, can you watch for me? He's a full code. He came in, just like Alex said, unstable angina, went into SVT earlier, gave some adenosine. He's now on AFib, he's stable. He has bilateral ACs, 20 gauges, full flush across beautifully, okay? So again, be thinking about pertinent information. You do not need to sit and give her a head to toe. She's gonna walk away. She's gonna be like, I don't have time for this. But you need to share pertinent information. If you're to walk away and if he were to code, she needs to know his code status. Okay, super, super important, okay? I'm notorious for watching for people and then forgetting. And then like going into the lunchroom and they're like, hey, how's my patient? I'm like, hey, it's great, let me just go back out. So again, make sure you know. Like now I write it down, okay? Especially when I'm charged and they're like, where's Kels? And I'm like wandering around not watching these people. So again, make sure you know what's happening with Mr. Albert. Okay, so Mary calls you back from your lunch. That's the worst when people call you back, right? Mr. Albert is diaphoretic, short of breath, and complains of chest pain that is now radiating to his back. He complains of nausea and proceeds to vomit, bummer, 200 mLs of yellow-green bile. Okay, so what's going on? What do you want to do? We can talk about it, you don't have to write it. What are you going to do? What's happening? What's happening to him? He's definitely not stable anymore, right? So what's going on? What do you want to do? You guys want a minute to type it so you can think about it? Take a minute, think about it, okay? So he was stable, now he's not. Okay, what labs do you want to send? What diagnostic things should you be sending? And then, are you just gonna leave him like that in chest pain, diaphoretic, radiating to the back? Okay? Let me tell you, he's had some dysrhythmias. What is that a sign or symptom of? Dysrhythmias. When I say dysrhythmia, it's not a normal rhythm, right? An arrhythmia, dysrhythmia. Something is off with the heart. Okay, so take a moment, type it out. Okay, so I like this one. I'm not picking on whoever did this, but I do want to point this out. It says, I want to see his strips. Okay, so you want to see his current rhythm. I think that's great. But again, in this moment, you want a 12 lead. You want the full picture because the lead that you're looking at oftentimes is just one facet of the heart. You want the full picture. So a 12 lead is going to be able to give that to you. So again, same thing, you guys, same thing. Isn't that nice for ACS? It's the same, okay? 12 lead, troponin. You are going to send this right now because something has changed. Well, Professor Bloor, it has been 6 hours, and we sent those labs already in the ED. No, things have changed, so you're sending new labs right now to capture what's happening right now. So you have a troponin and a 12 lead that you're sending, okay? Those are the diagnostics. And then, wow, amazing, it's the same thing, Mona. Okay, morphine, oxygen, nitroglycerin, and aspirin. Well, we already did that. You're doing it again, okay? Because there's been a change. Something has happened where maybe it wasn't a total occlusion before, but the plaque moved, and now we're having more problems. Okay, does that make sense? Dang it. My clicker doesn't always work, but now I know that the board, I can touch it. Okay, so this is what a 12 lead is. You do not need to read 12 leads. Please do not get freaked out, okay? But we know that this 12 lead shows a STEMI. STEMI, ST elevation, okay? Here we have it in lead 3, ST elevation. Here we have it in lead 2, okay? Here we have it in AVF. In order for a STEMI to be diagnosed, you must have a positive troponin and ST elevation in 2 contiguous leads. 2 leads looking at the heart, in the same area, okay? That is how you know that you have a STEMI, okay? Positive troponin and then ST elevation in 2 contiguous leads, okay? So Mr. Albert, he started the day with stable angina. Sad for him, it progressed to unstable angina. Now he has a STEMI, which means that he has a total occlusion of whatever, you know, you don't need to know where this is at, but he has a total occlusion in some sort of vessel in his heart, okay? Some sort of vessel in his heart. Okay. So, we already talked about this, the action plan and medications, right? He is getting Mona. We know he's having a STEMI. Where does he need to go? The cath lab, yes. He needs to emergently go to the cath lab, okay? Now, interestingly enough, most hospitals have a cath lab. But if you don't have a cath lab, you can also have what's called fibrolytic therapy, okay? Essentially, you want to break up whatever atherosclerotic plaque clot has formed in the heart. Why? Because your heart needs oxygen, okay? There's cell death happening, you want to treat that, okay? But most of the time, these people are going to be going to the cath lab to get a percutaneous coronary intervention, okay? Where they're going to fix the occluded coronary artery and promote reperfusion, okay? Does that make sense? Okay. So, Mr. Albert's taking a road trip. We just talked about that, to the cath lab. While awaiting transport, Mr. Albert flips into this rhythm. OMG, for Mr. Albert. Okay, so what are you gonna do? First of all, what is that rhythm? VTAC, okay? VTAC, ventricular tachycardia, okay? We got the mountains. There's no P waves. It's originating from the ventricles. Ventricular tachycardia. Okay, so the first thing that I want to do is what?
Check a pulse.
Check a pulse. Does he have a pulse? Okay. Now, let's say he has a pulse. He has a pulse and he has a good blood pressure. He's tolerating it. He's talking to you. What do you want to do? Syncardiogram. You could do that, or you could do amiodarone, okay, to convert this rhythm, okay, because he's stable. Okay, because he's stable. Stable amiodarone, okay, stable amiodarone. You could also use amiodarone when you have AFib, okay, because again, it's an antiarrhythmic. It wants to convert the rhythm back to the normal sinus rhythm, okay? Now, if it's unstable and he has a pulse, unstable with a pulse, meaning that he's hypotensive, he's diaphoretic, he's dizzy, he is altered, he's confused, okay? Then you could do syncardiogram, okay? Now, you look and you check, you turn your back, and you feel a pulse, and you're like, whew, I don't feel a pulse anymore. Uh-oh. What do you do? Defib, yes, defib, okay? In the perfect world, he's already hooked up to the pads. The perfect world is what I want you to have on your test, okay? If you don't have a pulse and you're in VTAC, you're defibrillated, okay? In the world that we live in, oftentimes people are not hooked up to the defibrillator right away, and so then if they are have VTAC, you're doing compressions, doing epi, right, that first drug when you don't have a pulse, and then hopefully once someone has the pads on, you defibrillate immediately. But we're talking about the perfect world, you defibrillate, okay? VTAC, VFib, defibrillate with no pulse, okay? Questions? Okay. Mr. Albert is coded for less than 10 minutes and we achieve ROS.
Hell yeah.
Return to spontaneous circulation. So he has a pulse, he's great, okay? He's taken to the cath lab where 2 stents are placed in his LAD. He is taken to the ICU for recovery. He is back in this rhythm. What do we think about that rhythm? Thank goodness, right? Thank goodness. What is that? What's the rate? 80, right? Sinus rhythm. So we fixed it, okay? Now, post cath lab, I need you to look at the complications. Okay, I need you to look at the complications after cath lab. What are we assessing? When Mr. Albert comes back, what are we assessing? What? Here we go, here we go. Take a minute, take a minute. Prior to your assessment, complications in teaching. You need to know this. Okay, after someone goes to the cath lab, what are you looking at? What complications are you on the lookout for? And what are you teaching? Take a moment, type it out. So this is how your test is going to be, you guys. You're going to have rhythms, and you're going to say, what are you going to do about it? So in your brain, you need to be able to identify it, and then you need to be able to figure out, well, what am I going to do about it? Okay? Some of them are just going to be ID, where you type in what the rhythm is, but others are going to be, okay, that's the rhythm, now what am I going to do about it? Okay? Does that make sense? I know, it's rough, but you guys got this, okay? Block 4, you can do this.
How many questions are gonna be in this exam?
I think it's between like 65 and 68, I have to look. It's on your syllabus, the exact number.
Thank you.
Uh-huh. Okay, so it depends, right? Where did they go? Did they go femorally or did they go radially? Okay? Did they do radial or femoral? Irregardless of where they want, you want to assess for bleeding. You want to assess that site and make sure there's no bleeding. Okay? You want to make sure that there's distal perfusion. So if they went radially, you want to make sure the hand is still being perfused. Okay? You want to make sure there's no bleeding here. Femoral, you want to make sure distally, right? You have a pulse, your leg looks warm, you got a good temperature, right? And no hematoma, okay? So if they have it femorally, they're laying flat for an extended amount of time, okay? They're laying flat, they're not getting up, they're bed rest, okay? You are assessing to make sure there's no bleeding, right? And if there is a hematoma, what are you doing?
Ice back.
What?
Pressure.
Pressure, yes, pressure. On the hematoma or above it? Above it, excellent. Pressure above it. Maybe call for some help to help, especially if it's expanding, right? So manual pressure on that hematoma above the site. Okay, you're not moving for 6 hours. You are assessing for back pain. What does back pain, after they get back from the cath lab, what could that tell us, back pain? Okay, bleeding, okay, a retroperitoneal hematoma, okay? I see a lot of blank looks, okay? So you need to take some time and look at the complications that can happen after a PCI, okay? I know, it's a lot, I know, okay? But ACS is all about going to the cath lab and getting fixed, okay? One of the things that you should never have, your patient should never have is chest pain after a PCI. They should never have chest pain. If they do, that indicates that the stent has restenosed. That's bad, okay? That's bad. So you're assessing for bleeding. both at the site and then retroperitoneally. You are assessing to make sure that they're not having any sort of weird rhythms or chest pain. Okay? Arrhythmias are very common. Okay, you need to make sure you're assessing for that. So take some time and look at it. There's a great chart in the book. There's a great chart that totally discusses all of the complications you can have. Okay? Questions? Okay, so now we're almost done, you guys. We talk about Mrs. Eleanor. I know, changing gears. Patient number 2. So Mrs. Eleanor returned home after dropping Mr. Albert off at the hospital. She was upset at having to leave, but understands the protocols. I obviously wrote this during COVID because no visitors. It was a wonderful time. Just kidding. I shouldn't say that out loud, but it was a different time. Okay. She sits down to eat her dinner and watch her favorite show. Obviously, it's Law and Order, right? Mrs. Eleanor is unable to eat due to some abdominal pain and back pain. She is diabetic and a little older than Mr. Albert. She's 65 years old. This is her rhythm. Okay, so again, we got some weird things here. Okay, what is my rhythm? It's 40, right? We counted the QRSs, there's 4 of them. So we can say that it's what? What kind of rhythm are we looking at? Sinus bradycardia, right? Sinus bradycardia. There's a P before every QRS, R is marked out. Okay, so sinus bradycardia. Now, if we had to venture to guess, what is going on with Mrs. Eleanor? She's got some factors, right? She's a woman. She's diabetic. She's geriatric. She's older, okay? She has some weird, non-specific symptoms. An MI, yes, probably so, right? Women present differently, okay? Diabetics present differently. Women present with fatigue. They have indigestion usually, okay? Maybe some shortness of breath. A man, however, is going to have more of the classic signs. Classic signs, I do this, right? There's lots of symptomology, but they're going to have the crushing chest pain, the back pain, the dysrhythmias. Okay, familiarize yourself with the symptomology of an MI and the different groups. Okay, now scarily, I think I just made that word up, people can have no symptoms, right? Oftentimes, geriatrics and diabetics can have silent MIs, where they just feel off. Okay, they just feel off. My grandfather, my mom called me, he was older, he was in his 80s, diabetic, history of coronary disease. My mom calls me and says he's having thumb pain. I said, hang up and call 911. He's having an MI. Okay? He'd been feeling off for a while. Okay? Did I know right away that he was having that? No, but we wanted to rule that out. Was he in fact having an MI? You better believe it. Okay? So non-specific. Non-specific. It can be silent. Okay? Women do not present normally. Atypical presentation. Okay? Make sense? Okay, I spent a lot of time talking about that, so you might want to review that, okay? So we won't type, we're just going to talk. Are we worried about that sinus bradycardia?
Yes.
In this particular instance, yeah. Okay, in this particular instance, yeah. I might not treat anything, I might not give her a drug because she's not totally symptomatic, okay, but I'm worried about it. Now, if she was hypotensive, and dizzy and lightheaded, what drug could I give her? Atropine. Excellent. Good job. Yes, absolutely. If atropine did not work, what could I do?
Push those heavy. Just anything.
Yes, you could, but I'm not going to, that, in the world you can do that, absolutely, but for this particular instance, I'm not going to teach that, okay? Okay. What else could you do? Symptomatic bradycardia. Atropine didn't work. What could you do? Where are my pads?
Pace.
Pace, exactly. Okay, you could pace them. You could pace them. Okay, that's what I need you to know. Symptomatic bradycardia, you start with atropine. If it doesn't work, you pace. Okay, yes, you can do push-dose epi. Yes, we do that at the bedside. But for my class right now, in this moment, I just need you to know atropine and pace. Okay? Okay, Mrs. Eleanor decides to call EMS. Maybe, yay, she'll see Mr. Albert. Who knows? She arrives in the ED with continued complaints of abdominal pain. She's placed on the monitor, and this is her heart rhythm. Okay? What are we looking at? Be careful. Look at your P's. Then look at your R's. Okay? Do they look pretty long? Yes, so we have a very elongated PR interval. What kind of rhythm is that? First degree. Okay, first degree heart block. Okay, what's my rate? 1, 2, 3, 4, 5, 6. So first degree heart block, rate of 60. Okay, this is how it will look on your test. A very long PR interval if it's first degree. Okay, it's going to be longer than what? What's the PR interval? Anybody remember? 0.12, right? So longer than that. You can count the boxes, but it's going to look like this if it's a first degree. Okay, so the PR interval is elongated with a first degree heart block. Okay? So what are you going to do for that? What should we do? She has a dysrhythmia. It's convert. You don't have to type. We can just talk because we got to finish this up. First degree heart block. What do you want some labs? Okay. So what should we send? Troponin. Wow, that's so weird. It's the same, right? It's the same. A 12 lead troponin. You see a pattern here, right? You see a pattern here. She's not complaining of any sort of chest pain, right? She has some pain, so we could give her some morphine. We could put her on some oxygen. We could give her an aspirin, right? Because we have a high suspicion that she's having some sort of cardiac event. Okay, does that make sense? Okay, Mrs. Eleanor gets admitted to the ICU for observation. The 12 lead shows N-STEMI with a positive troponin. Okay, so the third facet of ACS, we talked about unstable. Mr. Albert progressed from unstable to STEMI. Mrs. Eleanor has the other facet, an N-STEMI, okay, where she has ST depression, okay, and a positive troponin. So there's some rhythm change, but the take-home message is that there's that positive troponin. You're hooking her up to the monitor when she starts to complain of nausea and lightheadedness. So again, she's symptomatic, you guys. You notice she is more lethargic and not as alert as she once was. This is what it shows. What are we looking at? We already did first degree. Does the first degree look like that? Okay, so how I want you to look at third degree, okay? First degree is we have a couple, okay? They start fighting. They're spending less and less time together. So they're apart, right? So you have that PR interval elongation, okay? They're fighting, they're not getting along, they're spending less time. This is where they get divorced, okay? They're divorced and they are doing their own things. The P's are not correlating to the QRS's. They're divorced, they don't like each other, okay? They're doing their own thing. So the P's usually march out to their own drum. The QRS's march out to their own drum, but they do not correlate. Okay? PR intervals all over the place here, right? Okay, does that make sense? Think about it in that way. She's symptomatic. Her blood pressure is 85/51 with MAC of 57. We do not like that. What is our treatment? We're going to pace. Okay, we're going to pace. What if we had to say what her rate is? What's her rate? How many QRSs are there? 3. So she's 30. Okay, not good. Her cardiac output is low. She's not tolerating it. She's hypotensive. She's nauseous and lightheaded. Okay, she doesn't like it, so we're going to pace. Third degree heart block, arrow, pace. Okay? Okay, the pads, luge, capture, eat. You glance up. What do we got going on here? Okay, you're going to check a pulse. Okay? Oftentimes with VFib, there's no pulse. There's never a pulse with VFib. Okay? There's never a blood pressure. There's never a pulse. She's in VFib. Okay? What are you going to do for this patient? In the perfect world, you're going to defib. VFib, defib. That's how you're going to remember it. VFib, defib. You're going to defibrillate. Edison medicine. Okay? You're going to code her. Okay? You're going to give her 1 milligram of epi. You're going to be doing compressions. But first and foremost, you're going to defibrillate her. Okay? Does that make sense? Okay.
After that, you would do the ambulance?
You can? Absolutely. Yeah, good job. Dose is going to change a little bit. It's 300. 300, yep. Okay, so code blue, we talked about that. When you are defibrillating someone and you're in charge, right? You are looking at the monitor and you charge it up You are looking with your eyes and making sure everyone is clear. Do not lean on the bed, okay? It hurts. It hurts. Have I done that? Yes, sadly I have. So when you're in charge of the defibrillator, you're making sure everyone is clear, okay? And you're saying it out loud. When you're coding someone, there is closed loop communication. Physician says 1 milligram of epi, you repeat back to him 1 milligram of epi going in, okay? Doing compressions, hopefully at our hospital we have the Lucas, it's great. We love it, it's the thing that pounds on the chest, so we don't have to do manual compressions, okay? You achieve ROS, return of spontaneous circulation, with Mrs. Eleanor. Thank goodness. She earns herself a trip to the cath lab, and an LED and RCA is shown to be partially occluded. Both are stented. Okay, so again, we identified her of having an NSTEMI. Okay, NSTEMI, some ST depression, positive troponin, partial occlusion. Conversely, Mr. Albert, right, he had a STEMI that was a total occlusion. Okay, when you're looking at ACS, make sure you are understanding the difference between unstable angina, NSTEMI, and then a stem, okay? Mr. Albert and Mrs. Eleanor are in the rooms next to each other because you're fabulous terms. Post-MI, what are they at risk for? A lot of things. But what would be something that we have talked a lot about today that they're at risk for, that you're worried about? You go and you auscultate their lungs and you hear crackles. What are you worried about? Heart failure, okay? Anybody that has an MI is at high risk for developing heart failure, okay? What lab could I send after I hear those crackles that could help diagnose heart failure? BNP, okay? What conversely diagnoses an MI? What lab? Troponin. Do not get those confused, okay? Do not get those confused. Uh-oh, sad. Whoa, what's this? Asystole. If you put flatline, I will mark that wrong. It is not flatline. This is not Grey's Anatomy. This is called asystole, okay? This is called asystole. What are you going to do for asystole? You're going to do compressions, high quality compressions in epi. This is not a shockable rhythm, okay? This is not a shockable rhythm. You're just coding them, okay? Usually, if they progress to this, things are probably not going in the way that they need, okay? Okay, so the rest of it, we're almost done, are questions, okay? I'm gonna have you guys do these by yourself. It goes over AFib, A-flutter, okay? And then there's some, I think, heart failure questions too in here, maybe some ACS, okay? But the last two slides are just questions, okay? And you guys can do that at your leisure. Okay, so great job. I know it's a lot. You guys are like, my head is spinning, my hair's on fire. We made it through without having any visitors, which I'm pretty glad about, to be honest. So I will send you the blueprint for the exam, okay? I have to create the exam, but I will send you the blueprint, okay? Now, with ICU environment, I want you to be going over the lines. A line, central line, okay? PA catheter, what are they used for, okay? You may have some pain questions in there. That's review. You may have some death and dying questions. That's review. Utilize those quiz questions at the bottom, okay? They may be very similar to the questions you'll see on your exam. I can't make it any more clear, okay? Now, pharmacology. Please, please, please spend some time. Go over that lecture. Scarlett was a champ and recorded it for you, okay? Make sure you understand what drug does what, and then what do you expect? How do you know it worked? Mannitol, peeing is not making it work, okay? I'm gonna tell you that right now. Mannitol, how I know it worked, my ICP is down and I have better cerebral circulation and perfusion. My patient's not confused anymore, okay? So take some time and look at that. All of the drugs are fair game, okay? The nice thing is, a lot of them also have to do with cardiac, which you'll see on the cardiac section, okay? With cardiac, go over ACS, okay? If there's some time to spend, go over ACS. A lot of the questions have to do with ACS, okay? Spend some time in them. Look at what is going on with the PCI. What are the complications you're looking at? What signs and symptoms do you look at? We talked about it, right? Men, chest pain, back pain, it radiates. There's dysrhythmias that come with that MI, okay, with men. Women are atypical, okay? They have indigestion, fatigue, weakness, maybe some shortness of breath. And then geriatrics, especially people with diabetics, maybe it's silent, okay? So spend some time with ACS, okay? Mitral valve and aortic valve, you only have to look at both of those, okay? Heart failure, we talked kind of umbrella light of heart failure, spend some time on that. What do you do when you have heart failure exacerbation? Okay, what kinds of drugs can you anticipate? Okay, what lab can you draw to determine if they're in heart failure? Take BNB, okay? What labs do you draw for an MI to determine ACS? Okay, what do you do for that? What else? We talked about the heart rhythms. There will be just a couple, okay? Don't freak out. It's not gonna be like 10 rhythms you have to identify. But no, they're going to be like this, where you're going to identify and then what do you do about it, okay? Let's see. Make sure you understand what drugs are associated with each rhythm, okay? What you do with it. Flow charts are king. I love flow charts, okay? Let's see, what else? I think that infective endocarditis, pericarditis, aortic aneurysm, cardiac tamponade, all of that first PowerPoint, spend some time with those, okay? Majority though, I want you to know ACS, okay? Those are the most common things that we talk about and a lot of the questions, okay? Again, I'll send you the blueprint, I'll tell you the exam. Please reach out with questions, okay? Please reach out with questions. Go over the quiz questions, okay? In cardiac, I will tell you that there's some rhythms in there that you don't need to know. Utilize your list, your cardiac subject guide I sent you. So like, for example, there's like idioventricular escape rhythm. You don't need to know that, okay? There's torsades. You don't need to know that, okay? So there may be extra questions in there. It's not to trick you. It's not to trip you up. It's just exposure. Go off your cardiac subject guide, okay? And then make sure you're going over the soft chalk coupled with the book. Open your book, you guys. You may need more information than what's provided. Use these practice questions to go over and test yourself, okay? Questions, comments? Listen to that lecture. I tell you guys, the lecture is so important. I do not teach to the test, but I certainly steer you in the right direction, okay? Questions?
For complete heart block, do we have to do that?
Push it.
A complete heart block?
Yes, ma'am. First degree and third degree are definitely available to you on testing, okay?
Or how about type 1 and 2 second degree?
No second degree, you guys. You do not need to know second degree. Thank goodness, because those are hard. Okay, reach out with questions. Thank you so much for your attention. I so appreciate you guys. I know this was hard. Thank you for being flexible with coming here. I know it was different and hard, but I so appreciate your flexibility, okay? Oh, great question. I haven't decided. So the one thing that I probably will, but the thing about it, you guys, is that I analyze it. Oh, the other thing about that too is that I work that day. It's not an all day, I teach ECMO, and so, but just know that you're not gonna get your exam grade for a couple of hours, okay? Because I have to be able to look at it and analyze it. Remember, the amount of time works for you, okay? Because I have to look at it, and that's how I can, maybe if you score really low on an exam, I can give those points back, okay? I'm not afraid of that, I will do that,